Thank you so much, Dr. Chow. Thank you for the organizing committee to invite me and share with you kind of our experience here at UCI. As Dr. Chow mentioned, I'm a neurosurgeon here with a primary focus on primary brain tumors, that is tumors of the brain, as well as tumors that spread to the brain, so brain metastases. The American Cancer Society and the CDC every year produce really a nice volume of data on the incidence rate of the most common cancers that we see in both males and females. And it's no surprise that we see melanoma high on that list for both genders. But I think as you heard today, and as you heard many of the scientists and many of the clinicians with expertise in this space, that really we've had incredible advancements in the treatment of melanoma, that even though it's a common cancer, we are able to keep it under control in a very multidisciplinary way involving multiple lines of treatment, surgery, and radiation modality. Despite that, it's still one of the most frequent tumors I encounter during surgery, in part because there is some level of tropism for these tumors. That is, there's some affinity for them to metastasize and go to the brain. Melanocytes, after all, are really cells derived from neural crest cells from the central nervous system. So in addition to lung and breast, melanoma is the third most common brain metastasis that we see go to the brain. It can cause a spectrum of symptoms, and depending on the location of the brain tumor, it can give anybody a sense of just headaches alone, or really affect some aspect of movement, arm function, leg function. In more subtle experiences, patients can have speech difficulty walking. Sometimes patients can present with seizures or altered mental status, confusion. So all these presentations really, for me, underscore the importance of when we're evaluating a patient with a tumor or a melanoma metastasis, what are really the reasons they may need surgery as opposed to continuing on treatment or perhaps even radiation. As you'll hear from my partner, Dr. Jeremy Harris later, that we oftentimes don't have to do open surgery for these tumors. We can oftentimes just treat them with stereotactic radiosurgery. I think there's no better way to celebrate what we do as surgeons than to really give you real life examples of patients that came to us with this. I think one of the biggest advances in how we do surgery is really come down to being very precise. You can look back at literature 10, 20, 30 years ago, and in order to really open the brain up and actually do surgery, you had to make these large, very kind of barbaric, not cosmetic incisions in order to remove tumor. But now with the advent of navigation, which is really a three-dimensional rendering of somebody's brain MRI that allows us to superimpose it on the patient's surface landmarks, we can actually very precisely make a very small incision using the patient's MRI to resect a brain tumor. And you can see here, this is a patient with the incision mapped out with critical veins that you can see here, located in the back of the brain in the cerebellum, and the tumor located very closely to these two veins. We can make that incision, make a very tiny opening in the bone, make a very tiny opening in the outer coverings of the brain, and bring that back very nicely, and then put the bone back on in a very precise way with an excellent outcome. This is a patient that had a recent diagnosis of melanoma, was 71 years old, and was diagnosed a few months before he presented with seizures. And you can see the reason why he had seizures. He had a new brain metastasis from his melanoma right here in the temporal lobe, a very seizure-prone area or a very seizure-genic area. And this MRI captures that location very nicely and shows you the swelling and edema that's around the tumor that's irritating that brain, leading to the patient's presentation of seizures. When I saw this patient in the MRI, I actually recommended surgery to remove this, probably the best way and fastest way to remove the tumor and also control his seizures. Remarkably, when he was first diagnosed, he was started on Keytruda. And within 1 month of being on it, and by the time I actually had scheduled his surgery, his tumor was actually already gone. So we didn't even have to do surgery for this patient. And like I said, this really celebrates the spirit of this conference and the multidisciplinary nature by which we are treating patients with melanoma. This is a patient who actually presented in 2018 and thought this was not a blister that wasn't healing very well, but eventually sought attention, and this returned back melanoma. He did very well after a deep, wide excision of this. In 2020, he represented with disease now that spread to his knee. You can see it here on his PET scan, and was unable to walk. This required a total knee replacement. And unfortunately, this kept him in and out of ambulation for the next few years because of complications with this knee surgery, but eventually made it to 2023 where he was walking and doing very well. And I'll never forget this. He presented on Thanksgiving in 2023 with this large tumor here, affecting now his right leg function based on its location. So thinking that maybe tumor spread to his other knee, what in fact really was that this tumor was impacting and affecting his right leg function. I recommended surgery for him, and we did a very nice tailored craniotomy that you can see right here to remove the tumor. I recently saw him in clinic. This is him in clinic now, walking several years after that, doing very well. This is a patient who actually came into the ER thinking that she had a stroke. And if you look here ever so slightly, you can see a little bit of inability to kind of have a very symmetric smile on the right side of her face. She was looking in the mirror and she really thought she was having a stroke. She came in, had a full stroke workup in our ER. The stroke workup was negative, but I think the MRI was very clear why she was having this kind of face asymmetry. She had this history of melanoma that was and has been long in remission, but presented with this large, solid, and cystic mass that you can see here on this MRI. And knowing what we understand about the human homunculus and its somatotropic representation on the brain, this area right here of the brain, that's where our face function is. And if you actually move a little bit more forward, that's where speech is localized. And so this was a left-sided tumor affecting this patient's right side of the face. I recommended surgery for her, and we took her to surgery. Very nice, again, tailored craniotomy, small incision. And this is her tumor. As you can imagine, tumors are just like how we would think they are on the skin. They're also dark when we take them out from the brain with very, very pigmented appearance. This is her image before surgery. This is her image immediately after surgery on the next day with really a completely symmetric smile. Unfortunately, not all patients come to us in this kind of very controlled way. Melanoma is known to have a very unique hemorrhagic profile, and that is the tumors sometimes present and can bleed. And as a result, patients can go unconscious, they can develop seizures, they can come in extremis to the emergency room. This is a 34-year-old female who came to us with this large hemorrhage with a remote history of melanoma. But what made this case extra sensitive for all of us was that she was 32 weeks pregnant. So we had to act fast in this case. We rushed her to surgery, given the bleed and the mass effect on the brain. You can see here how irritated the brain is when her family found her unconscious. I want you to take note of this. This was an ultrasound that was done for her 1 day prior on the 16th when she came to us on the 17th. We took her to surgery, removed the tumor very nicely. Again, small tailored craniotomy. On 8/17, she came to us in the emergency department, took her to surgery. 8/23, she delivered her baby. And in September, she was already in our new hospital here, undergoing stereotactic radiosurgery for the cavity. And I think this really speaks to the multidisciplinary nature at UCI and how we really respond to every patient's needs and nuances in management. I want to end with an area that's something that's kind of very dear to my heart. I spent a lot of my training in this space. As you saw, I showed you many tumors. And classically, we've been very good as surgeons in approaching tumors from above, where most metastases go. But there are very unique cases where tumors appear in the sinonasal space, as we heard earlier, sinonasal mucosas, even melanomas of the eye. And I'll show you some rare examples of melanocytes that line, melanomas that line the inner lining of the brain. But around 20 years ago, there was a major revolution in the way we approach very challenging tumors of the base of the skull. And that included the introduction of an endoscope. An endoscope is a high-resolution 4-millimeter camera that we're able to put through the nostril of a patient and actually visualize and operate in this space from the nose without any incisions in the head, face, or cranium. As you can see, we can reach very, very challenging and deep structures in the brain that you can see here. This is the first case I did when I joined UCI in 2021. But the beauty of this approach, it really gives you a very panoramic view of the skull base to reach areas that really were not reachable before with surgery. As you can imagine, coming from this angle from above, you can only reach so much. But going through the nose allows us to reach really the base of the skull and really treat some very complex, unique lesions that we were not able to treat before. I spent 3 years of training post-residency, treating with studying with two of the pioneers who developed this approach. What I love about this is it takes imaging to a whole new level. First of all, these are high-resolution endoscopes that allow you to see microvasculature and tumor very intricately. We're able to use fluorophores. These are fluorescent dyes that allow us to visualize the tumor. We're able to render and create three-dimensional visualization and through virtual reality, model the tumor and its local vasculature. We even have a very, very tiny ultrasound that we can put through the nose and actually look for tiny tumors that could be trapped in certain areas that we can't see. This is a nice video, I think, that captures this fluorescent dye that we use now routinely when we're looking for tumors. As you can see here, we're looking with an endoscope, and you can see here the tumor is lighting up in green. You see that? So it's a very, very powerful tool that allows us to visualize things that we haven't seen before and in a very minimally invasive way. But I think the most important thing, it really has given us unprecedented access to these very, very challenging areas of the brain that were really abandoned by surgeons in the past. Here are two cases of a uveal melanoma that you can see here started in the orbit and has now spread and is now going right here in the very base of the brain, affecting the other eye. So really affecting now the other patient's, the vision out of the left eye. And so you can see this approach through an endonasal endoscopic approach really lends itself very nicely to decompression and removal of this tumor in protecting the patient's vision. This is a very challenging case and a very rare one. I've yet to see another one in all my years of training and practice. This is a 13-year-old boy who came to us with really what was thought to be a meningioma, a tumor of the outer coverings of the brain. But when we got in there and removed this, again, through an endoscopic endonasal approach, this ended up being a melanocytoma of the meninges, a very, very rare entity but one, like I said, that would be extremely challenging to treat from the conventional surgical approaches that we approached from previously. I'd like to end with this kind of final thought. Surgery, medication, radiation, I don't see these as competing treatment paradigms. I really see them as synergistic. Everybody here is committed to the goal of every single patient, every tumor board. All of these modalities are discussed, and we try to make the best decision for every single patient. And when surgery is the best decision, we certainly do it. And it's always complemented with both radiation and medication when possible. I want to just thank all of the faculty that you see here, and there are certainly many more that I've not listed, but these are my partners in radiation oncology that you'll be hearing from, Simon and Dr. Harris, who I work very closely with. Almost every single case that we talk about really undergoes this very, very deep scrutiny about what is the best for the patient and how we can alleviate the symptoms either with surgery or with radiosurgery or a combination of both. And here are all the oncologists and surgical oncologists and dermatologists that really are the front lines of this disease and have characterized it and have made profound leaps in how we manage this disease medically. But sometimes surgery is the right answer for certain patients given their symptoms. And I just want to thank my lab, very committed to also our research on primary tumors of the brain. I think there's no greater reward than trying to help patients through surgery and through research. And that is something I'm very committed to, and I'm fortunate to be able to do that here at UCI.